Welcome to On Becoming a Healer. In each episode, we explore challenges to being an effective healer, and that includes how we help and sometimes fail to help our patients understand difficult information. One situation that can happen in is pregnancy. A recent article in the New York Times bore the title, "These Prenatal Tests Are Usually Wrong." We want to use that story as a point of departure to understand how we can help our patients better. As usual, we have two co-hosts. I'm Stefan Kertes, here with Saul Wiener. Hi, Saul.
Hi, Stefan.
And crucially, we have a special guest, Rachel Campagna. Rachel is the lead prenatal genetic counselor at the University of Illinois at Chicago. Hello, Rachel, and welcome.
Hello. Thanks so much for having me.
To get us started, I thought we'd better make sure we understand what we're talking about before we get to the specific issues in the Times article. So some of us who are older and had our kids a while ago are aware of tests done before a baby's born that involve amniotic fluid sampling, like it's done in pregnancy. But we're looking at a different kind of test today, which is done in the blood. So can you just tell us what is non-invasive prenatal testing, which is the name of it? Why is it important?
Yeah, so non-invasive prenatal testing, or NIPT, it's also called non-invasive prenatal screening, or NIPS, or NIPS, is a blood test. So it's a non-invasive test for us to be able to screen a pregnancy for things like Down syndrome, otherwise known as trisomy 21. It also can do trisomy 18, trisomy 13, which are both chromosomal conditions that are caused by extra copies of their specific chromosome. And then it can also look at the sex chromosomes, though most labs will admit that the sex chromosomes aren't necessarily as good as kind of the standard trisomy 21 or Down syndrome or 18 and 13. But they are just a screening test. So this isn't a yes or no. I always tell patients that this is going to sort you into a high-risk group or a low-risk group, not give you a yes or no.
The Times article focuses on a special kind of genetic change that doesn't involve a change in the number of chromosomes, but something called a microdeletion. What is that, and is it important for our conversation?
Yeah, so microdeletions are basically small chunks of DNA that are missing from a chromosome. So they somehow got deleted. Sometimes they can be inherited from a mother or a father or a parent. Other times they're brand new in that specific baby. They are much more rare than things like Down syndrome, even trisomy 18, trisomy 13, which are much, much more rare than Down syndrome. So we definitely don't have as good of data on them. So it's always going to be a game of benefits versus risks.
The kinds of conditions that can emerge are pretty rare, but I learned about some of them in medical school, and I've had friends who've had children with these conditions, which are pretty serious. There's one called Angelman syndrome, and their baby had something akin to that. And it really was a devastating and difficult situation, even though they loved that baby immensely, both for them and for the baby, and for who became a child. But it was not at all easy. So I got the sense that this is a big deal if you're dealing with one of these syndromes.
Yeah, definitely. A lot of these diseases end up being very severe. We wouldn't be screening for them in pregnancy if they weren't severe. Like, we're not screening your baby to see if your baby's going to be colorblind. Like, these are conditions that can be really devastating for not only the family and that child, but for, extended family too. And all of that. And from not only from an emotional standpoint, but from a financial standpoint with the way our healthcare system works too. So there's just a lot of different things that play into it that are really important to think about when you're kind of giving this information to a patient and when a patient is electing to have one of these tests.
So one of the key things about these blood tests is that they're screeners that are normally followed by a follow-up test. And I wonder if we need to introduce a term here that might be used, positive predictive value. The way I learned about it and usually talk about it is if somebody has a positive test, what's the chance they actually have the disease in question? That's normally how I define it. But I wonder if you want to give us a sense of what screening means in this context.
Yeah, in this context, I think of positive predictive value in that same exact way of, yes, you got a high risk result. So now the positive predictive value is the chance that that high risk result is actually a positive result. When it comes to prenatal testing, especially, there's a lot of decisions that get made off of screening. And there's a lot of decisions that get made off of diagnostic testing. So, like I said, this is kind of the prenatal screening, or the NIPS is kind of that high risk, low risk categorization, where if you then pursued diagnostic testing, then that would give you that yes or no.
So what's the diagnostic test typically?
So the diagnostic test typically, and it depends how far along you are in pregnancy. So if you're someone who's really lucky and got your cell-free DNA or your NIPT screening done right at that first time that you could get it done, which is somewhere between 9 and 10 weeks, depending on what lab you're using, you may still make it in time to do testing in the first trimester, and that's done with a chorionic villus sampling or a CVS. That's a small placental biopsy, so it's just looking at placental cells, and then those get sent off to the lab for confirmation testing for whatever you screened positive for. If you don't make it to that testing mark, then you would have to wait till 16 weeks is usually the earliest that we would do something called an amniocentesis, where we take that sample of the amniotic fluid and then that sample gets sent off to the lab for confirmation.
Is it assumed, or should I assume, that people who have a test that definitively shows that one of these conditions is present will give serious consideration to terminating the pregnancy?
It's really, really patient specific. I would say one of the things that I always talk to people about when I'm offering this testing is, what are you going to do with this information? And I address that right at the beginning of pregnancy when I catch people early enough in pregnancy where they haven't had this kind of testing yet, is if you get a high risk result, would you consider diagnostic testing? Would you consider termination? All of that. I kind of broach it at the front end as much as I can. For some people, right off the bat, they say absolutely not, that I'm using this to help me prepare to better get like resources in place and all of that kind of stuff versus termination. So I would say, a good chunk of my patients, I would say probably 75% of my patients say, yes, I would at least consider it when we talk about it. Not always, that's not always what happens for sure, but I would say a good portion of people would at least consider terminating, but certainly not all.
So in the Times article, it tends to say for these screening tests, they're focused on the screening test, which is a blood test. And they say, for instance, that if the screening test is positive for a syndrome called Cri-du-Chat, then only 20% of the time will the baby actually turn out to have Cri-du-Chat on definitive testing. And they apply the word wrong. They say that the screening test is wrong 80% of the time. And I wonder if that's the way you would see it as well.
I hate the right versus wrong when it comes to this, because this isn't a diagnostic test. And even honestly, sometimes the diagnostic testing isn't so black and white. So I would never say wrong or right when I talk to a patient about this. I would always talk about it in terms of high risk versus low risk, like the possibility of a false positive versus the possibility of a false negative versus right or wrong.
In the next part of the conversation, I want to ask what's going on for patients and how they're learning about these tests. But before I do that, I'd like to ask my colleague Saul if he has any questions.
I'm interested in the question of whether these tests are appropriate when the risk of a condition is extremely rare and how you make that decision. So let's suppose a condition occurs in 1 in 20,000 women during pregnancy, which is sort of the range of some of these conditions. Some were actually even rarer and others were more common. And let's suppose that the test has a 1 in 10 chance, the screening test has a 1 in 10 chance of being, I was going to say wrong or right here, but I'm not supposed to use that term. But let's just use that for a moment. Let's just say that there's a 1 in 10 chance that it'll be a true positive. I think that's the correct term.
And in 9 out of 10 times, it's
and 9 out of 10
positive.
times, it'll be a false positive. Now, the question becomes, who should get that test? Obviously, it's a personal decision. Mm-hmm. Now, if a woman opts to have that test and she has no risk factors, we can say that in 19,990 of those cases of women who opt to have that test, they will get a negative test. And so even if no one even told them they were getting the test, they would very likely never find out because it's such a tiny, tiny, tiny minuscule number that would get a positive test. Now, if they happen to be in that tiny, tiny, tiny fraction that get a positive test, the 10 out of 20,000, now they have some important information, which is that there's a 1 in 10 chance that they have a child with a devastating condition. And they now have the opportunity to have a diagnostic test that is considered the gold standard. I think you made the point that it may not be perfect, but it's considered to be diagnostic. It's considered to be extremely reliable information. I'm talking about the amniocentesis or the chorionic villus sampling. So perhaps the way to think about this is not that this is a test that is wrong 90% of the time. I think the way to think about it is this is a test that can let you know if you are in a population that is at extremely high risk of having a condition, as a 1 in 10 chance of having a devastating condition in your child. And I think once you frame it that way, it starts to look like a pretty darn good test, right? And so the question becomes, who should say yes and who should say no to this test? If I were a pregnant woman, if I try to put myself into that situation, which of course is a big stretch, but if I try to imagine myself in that situation, and somebody said to me, here's a test that you can have, and there's a 99.99% chance that it's going to be negative, okay? But if it's positive, it means you are in a population that has a 10% risk of having a really devastating condition for your child. Would you want to have that test? And if so, you'd have to have an invasive test to find out if you're in that group. I would take that opportunity pretty seriously. And so I guess I'm curious about what the expectations are in the field. I was looking online. I noticed that the society that specializes in maternal and fetal medicine, I think, had a statement recommending against universal testing of women. But I don't know if it was up to date. And I was kind of curious about where the thinking is on this and what your thinking is on this and how you communicate this information to families.
I start with the guidelines that are given by the American College of Obstetrics and Gynecology, ACOG, SMFM, or the Society for Maternal Fetal Medicine, as well as ACMG, or the American College for Medical Genetics and Genomics, that's where we get all of our guidelines from. And then it really comes down to proper pre-test counseling, which is, why we have genetic counselors in the first place. The couple of times that I have ordered microdeletions is usually people who are late to prenatal care, and they come to UIC because they need, a second trimester ultrasound. And now we've got wonky ultrasound findings that don't necessarily fit with just Down syndrome or something like that. I'll at least offer them microdeletions because, hey, it may give us a needle to follow, but I don't just standardly offer it. And I don't think there are many genetic counselors out there that would standardly offer microdeletions.
Well, one of the things that's crucial here is you're a clinical genetics counselor. Is that right?
Mm-hmm. Yep.
And so when you offer things, you're doing it in the context of a conversation. But when I read the article in the Times, it came to my view that it might be that patients are learning about their testing options through very non-traditional pathways. Some of the slogans that were portrayed in the article included pamphlets that would say, "For your peace of mind," which I have to imagine is a kind of advertising directed at the patient. And I realize I don't understand how women who are pregnant even hear about the opportunity to have these tests other than at the doctor's office. What is coming to them? How are they hearing about it?
I think for the most part, it is coming from their doctor's office. It's often not getting marketed directly to patients. A lot of times it's getting marketed to the providers. And then, yes, all these labs do have patient-facing materials. So I will agree that sometimes I think the labs can be a little bit hyperbolic in their advertising on their patient-facing material. I do agree with the author of this New York Times piece of sometimes they're really, like I said, they're really hyperbolic and they're really over exaggerating kind of what they can give, or they're intentionally vague to make themselves sound better. So
yeah, I think the challenge is that there is a lot of, I would say, possibly intentional misleading going on by these testing companies, and we know that also happens with pharmaceutical companies. With their lawyers and with their experts, they can produce material that is technically correct, but nevertheless misleading. Mm-hmm. And I think that the New York Times is much better intentioned, but I also felt that while what they said was technically correct, was also somewhat misleading. And to give you an example, compare these two statements. Let's suppose I was saying to a patient, hey, how would you like to have a test to find out if your fetus could have a deadly condition? And the test is pretty terrible. It's actually wrong 90% of the time. The patient would be like, are you crazy? Like, of course not. Like, why do these tests even exist? Now, let's suppose I said it differently. I said, hey, there are some very rare conditions out there, and only 1 in 20,000 or so people get it, but there are a small number who do get this condition, and we have a test we can do that will tell you whether you fall in a group that has a 1 in 10 chance of having this terrible condition, and if you do, we could do a follow-up test to determine if in fact your baby is one of them. Would you like to have that? They're both accurate, and they come across completely differently, and I think that's why communicating this information is so important. The other thing that came out in the New York Times piece was that they had anecdotes. They talked to women who were devastated because they got this information over the phone. They thought that they actually had the condition. In a couple cases, they actually got an abortion. In other conditions, they were under extraordinary stress for a month or two to the point where they couldn't even work. And so I think the point there is that clearly, we as a health profession failed in a terrible way in communicating this information to patients. And I think the clinician is ultimately the one who is responsible for making sure that that doesn't happen. And while we're talking today about prenatal testing, this is not unique to prenatal testing. It happens across the spectrum of healthcare practice. I'm in internal medicine, and I could give you a number of examples where we see this. But I think as clinicians, we often forget how devastating information can be that we just think is, it's uncertain. And yet we have no awareness that the information that we just shared with the patient has shaken them up terribly. We've ruined their weekend. We've maybe ruined their month. And so I want to talk a little bit about communicating this type of information and avoiding these types of miscommunications. And Rachel, I'm curious about your experience with that, what you've seen in your profession, not just with genetic counselors, but with the field that you're in more broadly.
Yeah. I mean, I think you just hit on so many things of like, how do we effectively communicate this to people? And I think it's really the providers who are not giving patients all of the information that they need to make an informed decision. I literally just had a patient who said, my midwife told me about a test that can tell me about the gender of my baby. And I said, well, yes, there is a blood test that can tell us the predicted sex of the baby, but it also screens for all of these other things. And she ended up declining the test, even though she really wanted to know what the sex of the baby was before her 20-week anatomy scan, because she didn't want to deal with the anxiety that having a high-risk result for Down syndrome could give her. And that's totally her decision. And our providers, our OBGYNs, our midwives, even our residents are like pressured to see 20, 30 patients a day, and they don't have time to sit down and give patients all this information. They have time to say, do you want the test that screens for Down syndrome and the sex of the baby? And patient says yes or no. And then all of a sudden they screen positive for something that's not Down syndrome or a sex chromosome abnormality, which they probably didn't even know that was screening them for sex chromosome abnormalities either. And then I joke that I spend most of my day cleaning up after providers who didn't have the time because the healthcare system is pressuring them to put out as much possible revenue for the hospital system as possible. In a perfect world, I think, there would be access to genetic counselors everywhere, or, in a perfect world, I think we would be better at educating our providers about the nuances of talking about this kind of testing. Because it's never a yes or no. There's so many nuances. And I ultimately always leave it up to my patient that's sitting in front of me and not generalizing, well, this patient is like this, so this is probably what they're going to do. So I'm going to order it like this instead of like this. Like I always say, do you want to know the sex of the baby or not? No? Okay, we'll leave those off. Are you interested in screening for these smaller, more rare conditions? No? Okay, great. We'll leave those off too. And I work with the residents sometimes too. And I always tell them, like, give me what your 2-minute spiel would be to ask a patient if they want cell-free DNA. You have 2 minutes.
Yeah, I was going to say, it's clear we've talked about some barriers to clinicians doing that. And Rachel, you've highlighted time as one barrier, but you've also suggested that with a little bit of thought, a clinician might be able to develop a 2-minute spiel on the risks, benefits of testing. And to back up Saul here, I can think of countless other situations in medical care where we often say words like, you're at high risk for blank. That could be overdose when I prescribed opioids, or high risk for prostate cancer, high risk for stroke. But we could put in literally 1 or 2 minutes to lay that out and flesh it out a little bit more so that the actual decision we make is anchored to something that makes a bit more sense.
The more that we can, especially given, like I kind of said, the way our healthcare system works of just trying to see as many people in a day as possible, the more that you go home and like think about what your spiel is going to be, the faster you get at it, the better you get at it. And the more time you're able to then have that in your practice and like perfect it. And it's not going to be perfect every time, but like I have my 2-minute spiel that I give to patients every time about whatever kind of testing I'm offering them that day.
I'm not an obstetrician gynecologist, and so I can't really comment on what has to happen during a typical visit, but I am an internist and a pediatrician. And one of the things I found, and I'm just going to talk about internal medicine here, is that most things can wait if there's something more important. So what I found is that a lot of times we're turned into these efficient task completers where we feel like we have to get through our checklist of stuff. I've got to talk about that colonoscopy and that mammogram and that flu shot and so forth. And we end up doing that, but not doing something that's much more important, which is turning our chair around and talking with the patient about something that could have a huge impact. And all the other stuff that's on my checklist can go out the window because it's not going to happen anyway, and it can wait until the next visit. And I think that if I'm in a practice setting where I'm being forced, quote unquote, forced to see a patient every 15 minutes so I can earn, $260,000 a year or whatever it is, maybe that is something I should be asking about in terms of my own professional values. Why is it that I'm accepting a practice environment where I'm being forced to see patients under such pressure that I am unable to do what I know is right for my patients? And obviously, the Faustian bargain, the bargain with the devil, is that I get paid a lot to do that. But if I'm willing to say, I ain't going to go down that path. I'm going to find me a job where maybe I'm paid a little bit less, but I have more time with patients and I can practice the way I want. And also, I'm not going to be just an efficient task completer. I'm going to be somebody who always thinks about what's the best way to spend this 15 minutes or this 20 minutes with this person. And maybe I'm not going to get to everything on my to-do list, and we can maybe do that at the next visit. Then I'm going to do that as well. The question, of course, is saying I don't have enough time an excuse? If you don't have enough time to do things that are really important, then maybe you shouldn't be seeing that many patients at a time. And I think that's really the fundamental question that comes to my mind. So I kind of want to step back and get thoughts from, let's start with you, Rachel, about that general kind of way of looking at this.
I wish that our providers, whether they're at a public, like an academic institution or like, a university sponsored clinic or whatever, or if they're at whatever small community OB, I think it's very similar at both. I mean, as someone who's been to both a big university OBGYN as a patient and as someone who's been to, the small community OBGYN as a patient, I can see in my provider's face now that I am a provider and have that same face myself too, how strapped they are for time sometimes. And I don't know. I don't think that saying I don't have enough time is a good excuse, but it's the one that I hear the most often because our providers have 20 patients on their schedule for, a half day session for just an AM session and are expected to get through all those people in a semi-timely manner. And I don't necessarily, that's not a reflection on where I work. That's not a reflection on whatever OBGYN I've seen as a patient. It's truly just a reflection of our healthcare system that I think is very broken.
Absolutely. Now, we did another podcast episode with an internist who actually trained in our program some years ago, and he decided that he wasn't going to practice that way. He set up a solo practice, and he actually hires his own staff, and he has more time with patients. And so I guess what I'm saying is that, physicians are really lucky. They have a lot more flexibility over choosing their job. Not everyone in the world gets to set the parameters the way physicians potentially could. But this has sort of been something that we've seen with the people we've interviewed in this podcast, is that some do actually make that choice. They do earn less, but they're not facing the time pressures that most of us hear and talk about.
It can be tricky, Saul, when you sign up to work for a large organization. And I'm not, and I see that choice point being very serious because If you don't, you then do need to take on tasks of providing your own infrastructure for the work that you do, like the individual we interviewed. And if you sign up for a large organization, then issues of time are negotiated across the organization and subject to various parameters that you can't control. We don't have a perfect way through that thicket in the course of this podcast, but I think that Rachel's points and your points still stand up helpfully. One is that it can be good to have thought out a few shorter lines that will help you explain a risk equation. It can be good to take 2 minutes and to defer certain other tasks to the next visit if you possibly can, to make sure that somebody understands a serious decision that could cause them a tremendous amount of stress and anguish or be of real benefit to them, like various forms of prenatal testing. And I think also Saul, your point is right, though, that there are still variations in how organizations handle our time, and we can move between them and or try to set up our own organization. But we can at least consider, is this the right place for me if I have no way to accomplish what I wish to accomplish with patients?
Yeah, and I think what the New York Times article did highlight well is how devastating it can be when communication does not occur, when tests are ordered without consent, without discussion, and without people being informed.
But at the same time, that's the thing that killed me about that same article, is that there is another actor who is making choices about their lives and their work, which is the clinician, whether they're a nurse practitioner or a physician, or they're working in concert with a counselor. And in that coverage that we saw, the story was between corporate marketers and patients who were subject to it. And the role of this other actor, who's so central to healthcare, was eliminated and erased. And yet, if we want to address the problem, we cannot simply have a conversation about corporate malfeasance and innocent patient victims. There are clinicians, and these are the clinicians we train and we work with and we influence. And it bothers me every time a story is told that erases from the equation some of the most important actors in the healthcare drama simply to make a story sell. Sorry, I had to rant.
Yeah, no, actually, and I think, the irony of it is, I think the reason that healthcare professionals are paid the big bucks is because they are ultimately the ones who are supposed to be accountable, who are supposed to make sure that the patient is served well, who are able to filter what is being fed over social media, and who step up and make sure that the patient gets the right care, and that includes communication. And I think that's the point you're making, Stefan, and that's what was kind of missing from the New York Times article.
I think the other thing that was missing from this New York Times article is the fact that there are people who had this test and liked it. It completely fails to mention all of these women and all of these people who were impacted by this test who've had an amazing experience because of it, who were able to make decisions based on effective communication, A, and B, a test that's actually really good at what it was designed to do, giving people their ability to say yes or no to a test and their ability to say yes or no to diagnostic testing, and then to make a decision based on that. The fact that we're not talking about the people who this test really helped in making those decisions, or, whether they decided to terminate a pregnancy or whether they were using the screening or the diagnostic testing to just help them prepare better to raise a child potentially with something like, whether it's Down syndrome or, Prader-Willi or one of these other things that's screened for on some of these microdeletion panels. I think we're doing a really big disservice to the genetics and prenatal industry as a whole to not talk about the people who had this test and didn't have a traumatic experience and have, the information that they wanted to make their pregnancy better.
My take-home message from all of this, I think, is that for a company that's marketing a test, what they want to say is it's clear results. For a journalistic outlet that wants to get you to read, they want to tell you if the results are right or wrong. For clinicians and for clinical organizations that are trying to help patients, the actual question is not is it right or wrong, is it clear or unclear, but is it helpful or not? And what makes something helpful or not is all of the kinds of lessons that Rachel and also you, Saul, have been teaching us during this conversation. And to me, that's really key, is we're not trying to be clear every time. We're trying to be helpful every time.
I think that's wonderfully put, and probably a good way to tie things up.
Thanks so much, Saul and Rachel. This has been a really good conversation.
Yeah, I'm really glad that someone wants to talk about this. So here we are.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have, and you haven't already subscribed, please consider doing so now. Take care, everyone.